Hi, I'm Samantha. I'm a naturopathic medical student at Bastyr University in Seattle. I recently finished a course with Dr. Joseph Pizzorno and decided that I wanted to learn more from him. After the course ended, he recommended that I read his publications on PubMed. So you and we're going to do that together. This article was published in 2014 in the Integrative Medicine Encinitas, a clinician's journal, and is titled, "Niacin Doesn't Work and is Harmful," proclaimed the headlines. Yet another highly publicized questionable study to discredit integrative medicine. Oh, also written by Mark Houston, in addition to Joseph Pizzorno. All right. The impact of conventional medicine's use of the news and social media to widely promulgate misleading anti-integrative medicine research was recently highlighted for me. In July, several media stories, blogs, etc. loudly proclaimed, "Niacin does not work," or "Niacin fails again." Worse, they asserted its use was associated with increased adverse events. A Google search of "Niacin does not work, HPS2-Thrive, July 2014, yielded a remarkable 139,000 hits. Within a few days, one of my basketball buddies chastised me for referring him to a colleague who had prescribed niacin and red yeast rice for his elevated cholesterol levels. He asked why I would refer him to a doctor who would recommend something that did not work. Although I had not yet read the study, I assured him that there was a large number of studies proving niacin does work and is safe, and that he should not be misled by a single highly publicized study. Nonetheless, the damage was done, showing that news stories that we may easily discount because of our knowledge of the research can have a damaging impact on our patients and our relationship with them. So when Mark Houston, MD, asked me to join him in co-authoring a rebuttal, I was quite honored and receptive. After reading his excellent draft, I realized a clinically oriented rebuttal would be of interest to our readers. Following is my modification of Mark's excellent article. Signed, Joseph Pizzorno, ND, Editor-in-Chief. HPS2-Thrive. HPS2-Thrive was a study of an investigational drug, Tridaptive, Merck, containing both extended-release niacin, 2 grams, and the drug lapropiprant, 40 milligrams, to decrease the flushing effect of niacin. I really fudged that. Lapropiprant is a selective antagonist of the prostaglandin D2 receptor type 1, which appears to be the mechanism for niacin's flushing. This study included 25,673 high-risk niacin-tolerant patients who were randomized to either placebo or extended-release niacin plus lapropiprant. Saying that different every time. The primary endpoint was the time to first major vascular event, defined as the composite of non-fatal MI or coronary death, any stroke, or any arterial revascularization. So far, sounds like a good study that could help make niacin more acceptable for our patients. The primary composite endpoint of major vascular events was not significantly reduced. And then there's a bunch of numbers of the relative risk, the confidence interval, and the p-value. Relative risk 0.96, 95 confidence interval, and 0.9, so 1.03, p of 0.3. Serious adverse events were found in 3% of subjects in the active arm, although most were minor hyperglycemic problems. Myopathy generally was uncommon, 0.34% per Y, whatever Y is, but was 4-fold higher overall in the active arm and 10-fold higher among Chinese subjects. Now, the problems. Niacin not indicated. The study subjects were aggressively pre-treated with statin therapy, simvastatin, 40 milligrams per D, probably deciliter, achieving an average low-density lipoprotein cholesterol of 63 milligrams per deciliter, when the optimal is less than 70, and high-density lipoprotein cholesterol of 44 milligrams per deciliter, good is over 40, and triglycerides of 125 milligrams per deciliter, while optimal is less than 150. Okay, so within all those ranges. The National Lipid Association in the March 2013 position paper stated that in HPS2 Thrive, niacin was clinically irrelevant in the average study subject. The investigators tested a drug in patients who, on average, had no indication to take it. There was no reason to expect improvement from niacin in these optimally treated statin patients. Nonetheless, there were several positive effects of treated patients on extended-release niacin. And the LAPO, they're calling it ERNL. The LAPO, what is it? Laropiprant, which prevents the flushing. These included reductions in weight, blood pressure, lipoprotein A, a significant reduction in arterial vascularization procedures, p-value of 0.03, and significant reduction in cardiovascular risk in the subgroup with the higher baseline LDL cholesterol level, p-value 0.02. Discussed later in this article, there's been decades of research showing efficacy of niacin monotherapy in reducing cardiovascular events as well as total mortality. There's also research showing that niacin is effective in conjunction with statins when LDL cholesterol or triglyceride remain elevated and HDL cholesterol remains low after treatment with statins. In other words, niacin is effective when indicated as shown in the subgroup earlier in this article and other clinical research. Adverse events inconsistent with other studies of niacin with statins. HPS2 Thrive, unlike other studies using statins and niacin in combination, showed increases in serious adverse events. 3.7% absolute excess adverse events, including myalgia, 0.7, p less than 0.001, new onset diabetes, I'm not going to read all the numbers, new onset diabetes, gastrointestinal problems, skin problems, infections, and bleeding. This fixed high-dose niacin treatment may have contributed to dose-related adverse effects. Complicating the study, approximately 43% of the study population was Chinese. This influenced many of the adverse effects, especially the myopathy and skin eruptions, as noted in the paper. The absolute risk of myopathy in the placebo group was higher in China than in Europe, and the relative risk with extended-release niacin, ERNL, versus placebo was 5.2 in China as compared to 1.5 in Europe. China participants had 50 cases of myopathy per 10,000 versus 3 cases per 10,000 in Europe. My clinical takeaway from these numbers is that we need to be more careful prescribing both niacins and statins in patients of Chinese descent. The adverse events likely due to laropiprant. Laropiprant has several mechanisms of action that could either increase or decrease thrombotic risk and potentially cause adverse effects. Laropiprant with aspirin or clopidogrel induces a prolongation of bleeding time and an inhibitory effect on platelet aggregation ex vivo in healthy subjects and in patients with dyslipidemia, and may suppress immune function. This may explain some of the findings in increased infections and lack of cardiovascular efficacy in HPS2 Thrive. Niacin is effective when indicated. Niacin has been shown to provide numerous clinical and physiologic benefits. The clinical trials that showed cardiovascular benefits from niacin alone or with other agents are shown in this long table that I'm not going to talk to you about. So there's several studies, and then it summarizes their results, such as reducing congestive heart disease, reducing cardiovascular events, also reducing total mortality at 15 years, reductions in coronary atheroma, reducing carotid, I'm not sure what IMT is yet, and increasing HDL by 7 milligrams per deciliter, regressing carotid IMT, I need to look that up, and regression of carotid plaque and increasing HDL, reducing progression of coronary atherosclerosis with cholesterol. In a recent meta-analysis of niacin in coronary heart disease, definitive benefit was demonstrated for cardiovascular disease and congestive heart disease. These 11 trials of 9,959 patients found a reduction in composite endpoints in cardiovascular disease of 34% and a decrease major congestive heart disease event by 25%. There was no change in cerebrovascular accident. Interestingly, the magnitude of improvement did not totally correlate with improvements in lipid parameters. This suggests that some of niacin's reduction in cardiovascular disease events may occur through other non-lipid mechanisms. Note that niacin use for 3 years increased glucose levels by only 5 milligrams compared with placebo and did not increase diabetes mellitus risk. Based on the analysis of Guyton and others of the AIM-HIGH trial reported at the AHA meeting in November of 2012, niacin is most effective for cardiovascular disease reduction when the baseline HDL is less than 32 milligrams per deciliter and triglyceride is greater than 200 milligrams per deciliter. This is a table with the many physiological effects of niacin. I'm not going to read them all. These mechanisms include favorable lipid effects and non-lipid effects, as well as improvement on endothelial and vascular function and structure. It's a very long list. Still going. Lots of abbreviations. So, in conclusion, niacin is an efficacious agent for the treatment of dyslipidemia and prevention of cardiovascular disease as monotherapy, as well as with statins and other lipid-lowering agents. The vast majority of clinical trials with niacin or niacin with other drug therapies for dyslipidemia show significant reductions in cardiovascular disease, congestive heart disease, and carotid atherosclerosis. Point number 3. Therapeutic dosages of extended-release niacin has a relatively low side effect profile. 4. The addition of laropipirant may have induced many of the adverse effects. The data do not support the conclusion that niacin alone caused the adverse effects on clinical or metabolic parameters. And 5. Niacin monotherapy has many positive effects on lipids, such as LDL reduction and LDL particle number reduction. It also increases LDL size, increases HDL, HDL2B, HDL particle number, and HDL function. It reverses cholesterol transport, cholesterol efflux capacity, and triglyceride. Patients not at LDL goal or patients with cardiovascular disease and dyslipidemia with an HDL of less than 32 milligrams per deciliter and triglyceride greater than 200 milligrams per deciliter may benefit from extended-release niacin added to intensive statin-based LDL cholesterol-lowering therapy. Niacin has many non-lipid actions that are clinically important to prevent and treat cardiovascular disease and congestive heart disease. All right, final notes unrelated to niacin. It says, in this issue, few have had as big an impact on this medicine as my friend Jeff Bland. He is, with Susan Bland, the co-founder of the Institute for Functional Medicine, an inspirational speaker, the first member of the founding board of trustees of Bastyr University. I didn't know that. A prolific author, an expert spokesman to Congress. He has communicated and led in many venues. IMCJ is pleased to provide in this issue a review by Laura Pizzorno of his excellent new book, The Disease Delusion. While Jeff and Susan are widely appreciated for founding IFM, its remarkable success would not have been possible without the great leadership, inspiration, and wisdom of founding President David Jones. And my dear friend, InnoVision publisher Dick Benson provides us remarkable insight into this physician whose insight and clinical expertise has fundamentally changed not only what we practice, but how we practice. I especially appreciate how David came to recognize the importance of personalization in the patient's story. Equally important is his understanding that clinicians need to be science-using rather than to be used by the recommendations of generic science. I think we should start a groundswell movement to nominate David for Surgeon General of the USA. Think of how this would transform medicine and solve the healthcare crisis. IMCJ welcomes case studies because they provide important insight to real patient experiences. Mary J. Warpenberg, a professional massage therapist, courageously writes about her experience being treated with deep friction massage for radiation-induced fibrosis. This is an important story for our suffering patients recovering from cancer treatment. We continue our interviews of keynote speakers at upcoming conferences. Managing editor Greg Gustafson interviewed Howard Hinden, who will speak on sleep and immune system function at the American College for the Advancement of Medicine conference. I have been wondering how much of the dementia epidemic we are suffering is due to the dramatic reduction in sleep the past century. Looks like a good topic for a future editorial. I'm delighted with the guest commentary on sodium by David L. Katz. As I have looked into the research on diet-induced acidosis, yet another topic for a future editorial, the problem with excessive sodium has become quite apparent. I think a key reason low-sodium diets have not been shown to be as beneficial as expected is that decreasing table salt also results in decreased iodine consumption. As discussed in my editorial in June 2012, iodine deficiency is becoming more common, 50% reduction in intake the past 20 years, so salt restriction likely aggravates the problem. Great critique of the shamelessness of leadership in the medical industrial complex by John Weeks. Reminded me of a meeting hosted by Microsoft seeking advice from the healthcare community on ways to decrease their huge healthcare costs. Hospital presidents, medical directors of insurance companies, and directors of regulatory agencies were profound in their recommendations, most of which were some version of rationing and using their latest and greatest program to decrease costs. And then there was the lone, non-conventional invitee. Though 15 years ago now, I still vividly remember the response when I suggested that the only real solution of the problem was for Microsoft to improve the health of their employees. You could have heard a pin drop in the carpeted room. They all looked at me in fear as their institutions were dependent on ever worse disease needing ever more expensive and exotic interventions. Yes, we need the hospitals, insurance, high-tech interventions, etc. They truly save lives. But the only real solution to the healthcare crisis, as we all know, is to decrease the need for the huge medical industrial complex that now consumes 1/6 of the GDP. For the past several years, we have written a review of the annual IFM Symposium, held in May in San Francisco, Functional Perspectives on Food and Nutrition, the Ultimate Upstream Medicine, focused on the role of diet in health and disease. I thought the conference excellent, especially the playoff debate between proponents of the paleo, Lauren Cordain, Mediterranean, Mimi Guarneri, and plant-based diet, Joel Furman. Considering all the controversy surrounding the best diet debate, we decided to make this review more rigorous than those in the past. As the presenters provide numerous citations for their positions, our reviewer, Laura Pizzorno, read their references and reported what was actually found in the research. You may be surprised by what she found. And that's it. Back talk by Bill Brenda, there's nothing I can add. So, Niacin and other editorial thoughts on this publication of Integrative Medicine, a clinician's journal.